We might make a start.
Sure.
So, welcome everybody to this evening's event on insights and strategies in managing difficult patient situations. So, my name is Natalie. I'm a program officer at Northwestern Melbourne PHN. So, we'll just run through a bit of housekeeping to start with. So, firstly, I would like to acknowledge the traditional custodians of the land on which our work takes place. So, for us at Northwestern Melbourne PHN, we work on the lands of the Wurundjeri Woi-wurrung people, the Boonwurrung people, and the Wathaurong people. I'd like to pay my respects to their elders, past and present, and acknowledge that land was never ceded, and this always was and always will be Aboriginal land. I'd also like to extend my welcome to any Aboriginal or Torres Strait Islanders who may be present with us this evening. Welcome. So a little bit of housekeeping. If we could just make sure we're all on mute so that we don't get those lovely background noises of animals and children and cooking and snacks, that would be great. Any questions that you'd like to ask, please pop them in the Q&A box as we go along. We will be taking time throughout the webinar to answer questions. The other thing is if you could please make sure when you're logged in that your registered name on Zoom is your actual name so that we can take attendance, and that way we can mark that you've attended today's session. The session today is being recorded and a copy of slides will be forwarded out post the session, probably next week, given that it's a public holiday tomorrow. And we will ask questions anonymously, so please feel free. It's open, no such thing as a silly question. So, if you're not sure how to change your name, there's a couple of instructions there, or you can just pop it in the chat and our backend support person can give you a hand. Okay. So I would very like to extend a very warm welcome to Cheryl Wood, who currently works as a risk advisor at Avant Mutual. She is a very experienced previous practice manager, state APM committee member. She has an MBA. She's done work with the Inner East Primary Care Partnership, which was the pre-primary health network, pre-Medicare local post division of general practice. She's had an extensive amount of experience managing specialist practice, both here in Australia and overseas in New York City, which would be a completely different style of managing things, I would imagine. And we're so very lucky to have her with us this evening. So Cheryl, take it away. I'm so excited to learn some new skills today.
Thank you, Natalie. Thank you, everybody, for joining on this evening. I just need to share my screen. I won't be a moment. And there we go. So as Natalie said, if you've got any questions, please pop it into the Q&A. We'll try and take questions throughout the presentation just to be able to answer questions as they come to mind rather than all at the end, but certainly we can answer some questions at the end. If there are some themes and topics that have more interest and more questions, I'll put together some resources that we can send along with the slides next week. So thank you again for the introduction, and we will commence. So what we're talking about tonight is managing difficult patient situations. Giving you an overview of what we're going to talk about. We will talk about difficult patient situations, the types of patients that this might look like, complaints management and what you can do in your practice from a complaints management perspective, and also if and when it's appropriate to end the doctor-patient relationship, or in this instance, the practice-patient relationship. So most of the information that I present tonight will be relevant to practice managers, administration staff, as well as doctors. So feel free to share the information with doctors as well, because it might provide them with some useful information as well. So we'll talk about some general advice for difficult patient situations first. So from Avant, 15% of the clinical interactions that doctors are having with patients are perceived as being difficult by the doctors. 1 in 8 Avant claims involves the perceived disrespect towards patients. In most of these claims, concerns about disrespect were secondary to another issue. Claims often involve more than one issue. In 4/5 of claims involving disrespect towards patients, the primary focus was on another issue. It might be, for example, the patient management, treatment, or the diagnosis or delayed diagnosis. Disrespectful communication was a common concern in these claims. In claims involving disrespect towards patients, disrespectful communication was the most common concern. For example, the patient felt the doctor spoke rudely to them or ignored them or felt like they were being rushed. The doctor's attitude or manner was a concern. For example, the patient thought that the doctor was being arrogant, talking down to them, was inconsiderate of their feelings or situation. But also to think about the administration and the impact on the perception of a doctor interaction. Whilst our claims data relates to claims involving a perceived disrespect towards patients by a doctor, think about the impact and interaction with the practice admin as the patient arrives at the practice may have on the mindset of the patient. So if you think about a patient who attends the practice and the receptionist is busy, they're looking at his or her phone, talking to a colleague, or is in a conversation on the phone with a patient or somebody else, and fails to even acknowledge the patient's arrival, doesn't even look, the patient standing at the desk for what they feel like is a considerable amount of time, particularly if they've got young children running around and they're already stressed that they've got the children running around and they're trying to control them and just want to sit down. Think about what sort of impact that could have on their perception of the practice. And then that extends to what they might think that the doctor may have as their approach to them. But then again, if in turn the doctor is running behind and the patient's also not kept updated on the delay, this could further frustrate the patient and again has some bearing on what they think of the practice and how the practice feels about them, as well as the doctor. The patient may then enter the doctor's office feeling unwelcome or annoyed, that they felt that they were treated disrespectfully. This could then have an impact on their opinion of the doctor's communication and could impact on that entire consultation. And it's not necessarily the doctor's doing in the first place. Now let's compare this to an interaction where the patient arrives at the practice, is greeted in a friendly, open manner. If the doctor's running late, the practice staff apologise and continue to update the patient, showing empathy. The patient then enters the doctor's office, and whilst the appointment might be late, they feel like they were welcome, they were respected, and they may be less likely to read more into the doctor's communication and interaction and may not necessarily feel the same. So just thinking about, it's not just the interaction of the doctor with the patient, but certainly there is a way that practice staff can impact on the patient and what their perception of the practice and the doctor is. So talking about the concept of the circle of influence versus the circle of concern was first proposed by the late Stephen Covey in his book, 7 Habits of Highly Effective People. An example of this is that you need to go to the shops, but it's raining. You can't control the rain, but you're concerned about it. What you can do is to put on a raincoat, get an umbrella, or go out later. Those things you can influence on the impact of the impact that the rain has on you. What you can control is your attitude towards the raining day. Dr. Covey makes the point that if we want to be proactive in a crisis rather than reactive, we'll focus on the things that we can control, our response to the situation, and the things that we can influence. So, for example, in a medical practice scenario, this would include things such as having a policy on managing difficult patients and providing staff with education on how to manage difficult interactions. This is also known as our circle of influence, an area where we actually have the capacity to influence how we deal with a situation. As practice managers and administration staff, you need to let those things go that we can't influence. However, those are in our circle of concern, so you do care about them, you worry about them, but we can't really control them. So this would include things like the patient's behaviour. We can't really control that, but we can control our response to it. If you worry about things that you have no control over or are unable to influence, you end up getting angry, frustrated, and worn down. We often hear this from practices that the staff are getting stressed and upset at having to deal with angry patients, either over the phone or in the practice. There isn't a lot that practices and practice managers can do to stop the patients being angry necessarily, but as practice managers, it's your job to think about what you can put in place to influence the impact on the behaviour is having on staff. When you look at the circle of influence diagram, the circles impact on each other. So the more you worry about the circle of concern, the less control you have over other things as those circles do compress. So when you or the doctor, so again, talking about this could be in either situation, in the administration area or with the doctor interaction. If you see a patient who's visibly upset or angry or annoyed, it is important to recognise the issue and think about, is it the patient? Patients sometimes have expectations. They might have past experiences with the practice. They might have had an interaction that was unsatisfactory previously. They might have worry about their child, their own illness, such as having chronic pain. Patients can be uncooperative, hostile, demanding, disruptive, and unpleasant. Although it's important to remember that patients may think that the doctor also shows some of these characteristics, or the administration staff for that matter. They might have unrealistic expectations or be unwilling to take responsibility for their health. All of these factors can contribute to making an interaction with such a patient a challenging experience for everybody, the administration staff and the doctor. Thinking about the issue, is it you or the staff? Are you or they having a bad day? Are you tired or hungry? Is it the end of the day and you've had a really difficult day? Or are you dealing with a personal situation that's impacting on your manner or attitude? Is it late at the end of the day and you're needing to be somewhere, the doctor's running late, the patient was running late, and this is going to impact on your evening? Is it the system? Are there things that you can't control, such as parking, billing, wait times? Are there things that you can change? When faced with a patient who's visibly upset or angry, try to keep your cool and don't try to win an argument. Often if the argument escalates, it can be really difficult and frustrating on both sides to be able to come to a compromise and to be able to resolve the issue. Oops, wrong way. Managing expectations. The patients won't always verbalise what their expectations are. So, for example, the parent may have to get home to pick up children after school. However, the doctor's running late and this is making them agitated. If you're aware and they are unrealistic, reinforce the facts. So if the patient has run late and they're now expecting the doctor to run on time because they need to get out, keep them updated. So keeping them updated about what the expectations would be, the expected delay, particularly if you know that they've got school-aged children and their appointment is unlikely to be concluded by school pickup. If they're looking at their watch and you can see they clearly are in a hurry to get somewhere, if it's possible, perhaps offer to reschedule their appointment for a later time or day and acknowledge what the issue is and perhaps come up with some solutions. Set clear expectations with every interaction. You could do this by educating the patients about the need to be on time for appointments, particularly if the patient was delayed. Educating your patients about the length of time to set aside for appointments. And if they're likely to require a longer appointment time, to ensure that this is advised when their appointment is made. If you've got online hot doc or any other way that patients are making appointments, making sure you're educating them so that they're aware. If you've got several complaints that you need to deal with, this needs to be booked as a longer appointment, or we might need to reschedule for another appointment for you to come back. It's not necessarily going to help with the particular patient who's annoyed that they're going to miss school pickup, but may help in the future. And if you're educating all of the staff around what the expectations of the practice are, it can certainly help for them to understand, particularly if they've come in and realised, gee, I've just taken a lot more time than I need, and that's going to impact on other patients. Don't be afraid to apologise if needed. If the patient's expectations are not being met, for example, to be out on time for school pickup, again, acknowledge their frustration and apologise and offer whatever alternatives may be possible. What to do when you're dealing with a patient who is frustrated. You need to identify a situation as difficult. Name the elephant in the room. So don't ignore it. If you see somebody looking at their watch, talk to them and ask if there's anything that you can do. Are there any issues? Verbalizing the difficulty can help to build trust and opens the way to considering working together towards a solution. So what you may not be aware of in this particular instance is that the patient's partner is away and that they are the only one who can pick up children from school today, which is causing them some distress because they can imagine that their child's going to be standing at the gate and there's nobody to pick them up. Support the patient by listening carefully and showing empathy. People are more likely to listen if they feel they've been listened to, and be curious. Don't try to win an argument. If they were running late in the first place, try not to say, look, well, you were late and that's why, you're just going to have to wait. Arguing and talking over the patient or interrupting the patient can lead to a downward spiral in the interaction. Even a difficult patient can have a real problem. You don't need to win the argument, and kindness and showing that you're empathetic can really take the heat out of an argument. When dealing with a difficult situation, such as the case with a patient who's potentially going to miss a school pickup, set boundaries and expectations, offer solutions, and explore alternatives to staying for their scheduled appointment. If you do have urgent appointments at the end of the day, that you can offer them to come back, depending on the purpose of their appointment. Maybe it's possible to offer a telehealth, but talking to them about what can be done and what can't be done. You may not be able to offer them an alternative, and maybe the alternative is that they need to stay and they just need to contact the school and advise that they're going to be late. But showing that you're willing to help and come up with a solution can often help them at least alleviate the concern. Okay, so we're going to talk about the types of patients. Have we got any questions at the moment, Natalie?
So there is just a couple. I think that you've answered them. So I think there was a little bit of interest in your first slide about having a chat about what Avant sees from patient complaint perspective. Are they a lot of, and I acknowledge that we sort of talk about that often, it's not the primary complaint, but it support, it adds more meat to the complaint, if that's so. The phrasing used was, are most of the complaints valid, or are they unrealistic expectations from the patient?
It really does depend. Some patients really do have a valid reason. Some doctors always run late, and some patients have an expectation that they're going to be on time, and maybe they don't attend very often. So we see lots of different complaints and claims that come through. A lot of the complaints that might come through that we see will often relate to the doctor and the interaction in the consultation, where the patient might complain that the doctor really didn't listen to me. I have had these symptoms and he has completely been disinterested and hasn't taken any notice of what I had to say. And I've then had to go and make another appointment with another doctor. And then they've found that I actually do have a real clinical issue. Things like that are really important to ensure that from an administration perspective, that you're looking at your schedules and making sure there's enough time for the doctors to be actually able to spend the time they need to with the patient, and educating the doctors too around ensuring that they take a breath. So they might speak about what it is that they're talking to the patient about. They might have a recommendation, but then to stop and allow that time for the patient to respond. If you're providing the patient with information, check back to see that they actually understand. This is certainly relevant if you're doing a consent process or any of those things where you need to really give the patient an opportunity to provide their response. So we'll often see that patients feel like they weren't heard because they haven't been given the opportunity, and they know the doctor's only got 10 minutes, 15 minutes, and they feel like they're under pressure. They need to wind it up as well. So I think it's a mixed bag in relation to the complaints, whether they're legitimate or it's just patients. And sometimes it is just patients. We do see vexatious claims quite often.
And it's the nature of dealing with people, because no human is perfect and we all interact differently, and sometimes those interactions don't go smoothly. There is another question about handling requests for tests or imaging when it's not required, and then the patient states they're going to make a complaint. I think that ties into your vexatious complaints and, and it comes down to clinical autonomy as well. And I'm sure you'll probably cover this off a little bit later in the webinar as
Yeah,
well.
and that probably then comes down to the clinical side. As you said, it's the clinical autonomy, but then it gets down to the doctor really informing the patients, because you will have patients who have expectations about, I need to have this test, and this test, because I think that this is what's wrong with me. And it's really up to the doctor to ensure that they inform the patient of the reason why they're not recommending a test, or that test isn't something that's going to be appropriate in this situation, and making sure that they inform the patient of why what they're expecting isn't going to happen. Also documenting. So certainly going back to your doctors and informing them that if a patient comes in and has a particular concern, has requested a particular test, if that's not indicated, put a note in the medical record. So if the patient does make a complaint, then Avant or whoever the MDO is will be wanting to look at your medical records to be able to review what the clinical decision making was. And if we do need to defend a complaint or claim, having that record as to the reasoning why will certainly help with that. So it's really about informing the patient and educating the patients about what is and what is not appropriate.
Mm. There's also just another question where, and it's from a GP, so around where they, spending quite a significant amount of time with a patient and really not identifying what the answer is to what the patient's wanting to know. Patients getting upset that they have to wait in the waiting room and, requesting that the patient come back another time, and the patient getting angry and abusive. So strategies to manage those situations where really you've done all those communication strategies, and potentially you've managed your waiting room, but the patient expectations just haven't been met.
And it can be really difficult. Managing the expectations from that time sensitive, if they've had to wait and they're still not getting anywhere with it, it may be appropriate to talk to the patient and really understand what their expectation is. They might have a concern that perhaps isn't relevant in their case, but it's material to them. So if it's a material concern to them, the doctor really should at least give them the opportunity to address it. If there is something that can be done to allay their fears, if they feel they've got symptoms that my friend has these symptoms and therefore this is probably what is a problem for me, ensuring that you're explaining to the patient why this might not be the case. If it's appropriate, sending them for a test or referring them if they prefer, if it's appropriate to refer them to a specialist or elsewhere, just giving them options. It can be difficult because you will have the worried well, and the worried well will want every test under the sun to make sure they're actually well, and it's really not appropriate and it's a waste of resources. So some of those patients, it's really about educating and giving them options. And if it comes to the point where you feel as a GP, if you feel that the trust isn't there for the patient or that the patient is second guessing you, certainly saying, look, and if it's a group practice, saying, look, I understand that you don't feel like you're getting the answers you want from me. I'm more than happy to have one of my colleagues consult with you if you want to come back for a second opinion. Giving them an option often will assist, because it will break that concern and they'll at least feel like they're being heard. And the other doctor might say exactly the same, or if they are sent for tests, it might come back to show that actually the information that was provided in the first place was completely correct. So it's really just understanding what the concerns are of the patient and making sure you document.
Absolutely.
Yes.
All right. So that's it for the questions. So we'll move on to the next section. Yeah.
Okay. So there's lots of types of patients that you'll see in your practice. So the abusive patient, we all know these people. We recognize these people. It's confrontational when a patient becomes abusive. This might involve verbal or physical abuse or confronting behavior. They might be rude or aggressive, threatening, demonstrating, harassing behavior. They may send rude or confronting emails or letters, make telephone calls, and in those extreme cases, unfortunately you don't see them often, but in extreme cases they may even go as far as making threats of self-harm or harm to others. Putting the patient as your customer is often a different idea, if you like, or a different concept than putting the patient as somebody that needs you and can't if you can't give them what they need. Putting them as a customer can help them also to get the feeling that you want them. When dealing with anger or aggression, having the mindset that the patient is a customer is more about trying to help and trying to get to the bottom of the problem and solve their problem, rather than just seeing the patient as an annoyance. And it can be really difficult because some of these patients can be a little bit annoying, but trying to give them some sort of an answer, whether it's going to be one that they need, but trying to get to the bottom of their problem. So, for example, I was out visiting a practice one day and a patient walked in with a really unhappy, unsettled baby on her hip. And the receptionist just flew up and said, "Out, you can't come in here without a mask." And the patient was trying to put it on, but she couldn't because the baby was clearly really distressed and upset. And to that end, the patient was clearly upset because she's dealing with two difficult issues, with the receptionist saying, "This is our policy, you must not be here." And she's got a distressed baby that's going to then potentially impact on a room full of patients. But compare that to how the interaction would have gone had the receptionist flew up and said, "Oh gosh, I can see that you're really struggling today. How can I help?" It's just a really different mindset, and looking at it from the patient's perspective that she's struggling, and how can we help to try to alleviate what you're going through right now. If you do see abusive patients, advise the patients that you're aware of threatening or aggressive treatment of staff, particularly if the doctor is aware of that, to talk to the patient and just to inform them that it's not acceptable. Adopt a firm and authoritative communication style. Have good documentation, particularly if it gets to the point where you need to end the doctor-patient relationship or the practice-patient relationship. Ensuring that you've got good documentation can help to, should there be a complaint or claim because of that in the future. End telephone calls and consultations if the patient becomes abusive and confronting. I used to say to our staff, even if you're all on the same level in the practice, if somebody's being difficult on the phone or abusive, putting them on hold and putting them through to somebody else. Often they feel like it's been escalated to somebody more senior, and it might be the cleaner for all they know. But as long as it goes to somebody else, sometimes that can break that aggression. Consider requiring patients to sign a patient contract style or a formal agreement for patients with recurrent and severe behavioural problems. The practice might consider terminating the practice-patient or doctor-patient relationship if required. The practice really should develop a policy and procedure for dealing with abusive and aggressive patients. Perhaps consider placing signage in the practice, on the website, on the on-hold message, or in the reception area stating that the practice has a zero tolerance for abusive behaviour towards its admin and clinical staff. A patient code of conduct might be something you consider adopting. You could direct the patients to the website or provide them with a handout that outlines the potential consequences of continual unacceptable behaviour. So if somebody is regularly abusive to your staff, maybe you look at having a handout that you can provide them to say, "Look, we're aware that you've been exhibiting inappropriate behaviour. We have a zero tolerance policy in this practice that you need to be aware of, and you need to be aware of what the ramifications are if this behaviour continues." Angry patients. So first we'll explore angry patients who are reacting to circumstances. I think we can all agree that at times the health service can be frustrating, particularly when there's a lack of doctors and staff, that patients often can't get in for an appointment when they want. And anger may be a response to some of the inadequacies of the system. The expectation might be unreasonable, but those unreasonable expectations are not being met. So you may be getting a sense from the early warning signs of aggression, and we generally know what that is, like heightened stare, body posture, tensing of fists, hands making fists, and all those sorts of things to show that the patient's becoming aggressive, white knuckle syndrome. And of course, the first thing is whether the anger is normal and justified. The health system can be really frustrating, and patients in an emergency department, for example, are really worried about their health or their loved one's health, and it might be quite rational to be aggressive. Not appropriate, but it might be rational and understandable. In fact, I can think of lots of instances where the aggression has been easily understandable, the sorts of things that you might experience if you were in that person's shoes, and has no moral badness about it. Getting back to recognizing the issue, though, reflect on your role in the interaction. Is there something that you did potentially, or one of the staff have done, to inflame the patient's anger? Is there something that you could perhaps try to do to calm or de-escalate the patient's anger? Prevention is certainly the key. And again, managing the expectations of patients and educating them on the expectations of the practice and the expectations of behaviour at the practice can assist. And training staff to be aware of those early warning signs, so that if they see that a patient is getting angry, perhaps to alert the practice manager just to be on the lookout and monitor the behaviour. Certainly when you're dealing with angry patients, keeping calm, use neutral tone and adopt an open body posture, avoid becoming defensive or taking comments personally. Sometimes it can be really difficult, but trying not to take them personally. Seek to de-escalate the situation rather than potentially escalating the patient's emotion by demanding that they behave in a certain way. You could make comments like, I can see you're upset. How can I help? What can we do to make things better? This is really a much better approach than being confrontational and saying this behaviour is unacceptable. That's likely to inflame the issue. The notion of de-escalation is one that you can work at with your staff, providing them with training around how to de-escalate a situation. Things like apologies, again, how can I help? What can I do to make things better? And understanding where they're coming from. So de-escalation is by identifying what the problem is and clarifying that their behaviour is upsetting and intimidating or interfering with the care of either their own care or the patient or a patient or relative's care. And that can be really, really effective to de-escalate a situation as well. They may not necessarily realise, they might think that they're advocating for the patient, but understanding that actually you're impacting potentially on the care might assist in de-escalating. We all meet angry patients, and of course the worst thing you can do is to meet anger with anger. So if you're feeling particularly heightened in your anger senses, maybe again transferring to somebody else in the practice. If you can get the practice manager involved, if you are the practice manager, just getting a receptionist or somebody else to be able to talk to that patient and perhaps potentially give you a timeout, but also hopefully be able to calm the patient in the situation. Aggressive patients, again, raise voices, name calling, swearing, prolonged and intensive glares. There's zero tolerance policy in the practice, etc. And it's all well and good, but when you are at the coalface dealing with the aggressive patient, a zero tolerance policy doesn't get you very far, because they're not particularly receptive to you telling them we have a zero tolerance policy, so you must stop that. And there is a continuum. Anger that can be reasonable, explainable, understandable. Angry feelings that are misplaced, patients often realise that they are being irrational. Borderline state, some patients can be out of touch with reality. And then obviously you have the other end of the continuum, psychotic, mental illness, drugs. And we would always say in practices, it's really safety first. If you feel at all uncomfortable, excuse yourself and leave the room if it's possible. You then reset with somebody else, talk it through with someone else and say, look, I really felt uncomfortable. I felt like that person was intimidating. And then you don't go back to that room unless you've got someone with you, unless you're prepared for that properly. and whether that's in the doctor's consultation room or in the reception area. What we don't want is people staying too long and being assaulted or being significantly threatened. Try not to antagonize the patient or the family member, whoever's getting aggressive. Sometimes people can be presenting in a very irrational way, and it seems wrong to not contradict it, but if you're getting heightened, there's little to be gained in having who's right in the moment. So maybe it's a matter of saying, look, I think we probably just need to take a break, a time out, and why don't we step back out into the waiting room, or why don't you take a seat and we'll have a think about it and then we'll come back. Some hints are who you could say to them, who would you like me to call? How else can I get involved? Who else can I get involved? Family members, particularly parents, will put some inhibition on if it's a young person. I mean, they'd be my sort of starting point. But certainly safety first, making sure that you enact practice safety procedures such as a duress alarm or calling 000. We would always say to practice. So lots of practices will have policies and procedures around what would happen in these instances, but they don't practice it. And if something were to happen, people will run around and not realize. If you need to have somebody who's actually responsible and have the plan that's played out before it occurs, and it should all be documented in a policy. If anything were to happen as well, you do need to make sure that any issues are documented, so that if you need to recount the scenario, you can. But again, don't antagonize or try to win an argument with a patient who's being aggressive. And where possible, try to understand the reason for the aggression. Sometimes it's really difficult and sometimes it's not possible, but to try to at least demonstrate that you're at least trying to understand the issues. And we also see patients with unrealistic expectations. Some patients are really high maintenance. They expect everything to be done because they want it to be done. I'm here, I expect exactly what I want. These patients like to tell the doctor what to do. As you said before, they might come in and say, look, I feel like I have this condition. I need this test, and this test. These patients are often non-compliant as well. They might request all of these tests. They have the tests and they find that actually they're quite healthy. And you might recommend to them that they make some lifestyle changes, but they know better than you, so they don't do it anyway. They might expect instant and perfect outcomes. So they might be feeling pain. They expect that whatever you're going to do, they're going to come out and it's going to be solved immediately. They often will make threats of legal action if they're denied what they want. So again, making sure you manage patient expectations, educate them, document. If they request something that is inappropriate or not required, make sure you document, particularly the clinical reason why that might be denied. And with patients with unrealistic expectations, setting clear boundaries based on your expertise and skill set, certainly from the clinician's perspective. Explain what you can and can't do, and be prepared to direct them appropriately. Don't go beyond your comfort zone and do things or not do things because that suits the patient. Adopting a shared decision-making approach. And that's really important to ensure that you're educating the patients and they are part of the decision-making rather than the doctor explaining this is what we're going to do. Giving the patients an opportunity to contribute to the discussion and make those decisions can often help those patients who have unrealistic expectations understand why those expectations can't be met, but maybe there's something else that can be done. Good documentation to support these discussions, and avoiding approaching difficult patients with an inappropriate heroism. Yep, we'll do all of these tests and we'll do everything we possibly can. Be prepared to say no. Sometimes patients need to hear no, that they can't just have everything that they want. There's a room full of patients. We can't go through all of these things with you, and be prepared for the patient to go elsewhere. Sometimes they will say, look, I'm just not having my expectations met, and that is fine. Mr. Smith, I completely understand that you feel that you need to go elsewhere. Just let us know where we need to send your medical records, and we'll certainly send the information to assist your next doctor to be able to meet your needs. Non-compliant patients, we love these ones. They usually don't follow your advice. You give them lifestyle health recommendations. They don't follow with it. They continue in the behaviours which are detrimental to their health. Apparently they can't or won't comply, or they forget to comply. Good relationships between doctors and patients are grounded in trust. You need to utilise systems for follow-up of investigations and significant missed appointments. So certainly making sure that you've got systems in place to monitor if patients are missing appointments. Certainly if they're required to come back for a follow-up and they haven't, and it's a clinically significant reason, ensuring that you've got flags on your system to be able to identify this. Raising it with the doctor to ensure that the doctor's aware. If it's something that's important that they really need to come back, having systems and processes in place to contact the patient and ensure that you're doing everything you can to at least let the patient know the risks of not returning for follow-up. Exploring reasons for non-compliance. Sometimes people don't do things, particularly this day and age. Maybe it's expensive. Maybe recommending that they change their diet. Maybe they can't afford to eat healthily, or they might have family issues at home and they just can't do what's been expected. So try to understand the reasons for non-compliance. Sometimes people just have a bad attitude and they think that they know better, but sometimes it's actually real reasons that probably should be investigated and explored with the patient. Documenting discussions and advice that's given in detail. It's often really useful, particularly for these non-compliant patients, to provide them with a handout that they can take away, that they listen when they're in the consultation or listen when they're talking to the receptionist, but they don't really hear. So giving them something that they can take away and actually digest it at a later time is often quite useful. And the goal really is to train these patients on ownership and compliance. Let them know, look, we've given you the advice. This is what you're recommended to do. If you don't do this, this is what the potential risks are to your health. So there's other kinds of difficult as well. So we talked about demanding, aggressive, unrealistic expectations. And there's other types of difficult patients in the practice. For example, separated parents. And that can be really challenging in a practice when you've got separated parents and the dad comes in, but you know that the parents don't get on. So there's lots of challenges in practice and it can be really difficult. And we would always recommend having policies and procedures in place that actually provide some guidance for staff in dealing with these things, looking at what training opportunities there might be for dealing with difficult situations. And at the end of the day, just managing the expectations of the patient and informing them what you can and can't do. Are there any other questions at the moment, or I'll go on to the next slides?
I think we can probably move on. There was a question where someone's popped in a scenario that happened to them in practice that was quite challenging, but I think we've probably addressed some of the strategies that could be used in that situation. So I think if we keep going,
okay. And if we've got time, we can
we can come back
onto that one.
Yeah.
Okay, no problem. Okay, so after conversations, so it can be really difficult when you've been in these challenging situations where you've been confronted with an aggressive patient, an abusive patient. We would recommend to you after such a situation to reflect on the situation, try and stay calm and professional in the situation and try to see it from the patient's perspective, but certainly reflect on how it affected you. So have a debrief with a colleague after a difficult discussion. So certainly from an administration perspective, speaking to the practice manager about, gee, this is how I felt in this situation, and using it as an opportunity. And we always say using any issues and problems as an opportunity to actually be able to learn and improve and change things. So, gee, I had a really difficult time communicating with this particular patient. He was being aggressive, and these were the things he was saying, and this is how he was behaving. And then think about, well, is there an opportunity as a practice that we can do some professional development and actually build some skills and capacity in our staff to be able to deal with this, and looking at our scenario planning around how do we deal with it if there is an aggressive patient at the front desk. What can we do to put in place to try to curtail that and deal with it? Documenting the scenario and the situation, making sure you keep a record for various reasons. Obviously, if it's a difficult conversation with the GP, making sure it's in the medical record, but also as practice managers, keeping aware of the fact that you've got work health and safety requirements and obligations as well. So documenting situations, what's occurred, what's been put in place to deal with it and address it. If the staff member in particular has been given some training or offered counselling to help them to debrief on what's actually happened, and getting them support if needed, or for yourself particularly as well, getting support if you've got an EAP, if it's useful to be able to talk to somebody outside of the practice. But making sure, one, we've got to be on top of and aware of patients and their concerns and dealing with their concerns, but also personally, and making sure you look after yourself and looking after your staff as well. So from a complaints management perspective, and this is our bread and butter because Avant being medical legal advisory service, we get lots of these things that we deal with for our members, whether it's administration, practice managers, or with doctors. So there are lots of reasons why patients make complaints. Patients often make statements like, the doctor didn't listen, I was ignored, the receptionist was really rude. Building an atmosphere of mutual respect will assist in the event that something unexpectedly does go wrong. If there's an effective communication with the patient, it will assist in dealing with and resolving a situation at hand. So getting back to our discussion, trying to identify and acknowledge if there is potential issue with a patient and try and name the elephant in the room, and to understand what it is that the patient might have a complaint about. Certainly from a complaints perspective, and this is where from the risk advisory service, we would recommend that practices have a good complaints process. Feedback and complaints, we'll often say it's an opportunity for patients to be able to provide good and bad feedback to the practice. Claims and complaints to outside bodies often happen because a person is unhappy about something and they have felt that they couldn't complain or provide their feedback directly to the practice or get satisfaction about their complaint. They find it really easy to complain online to professional bodies such as the Healthcare Complaints Commission, Privacy Commission, or AHPRA. And that's why I put this slide up. These are the homepages of these areas, really easy to put in a complaint. AHPRA often, if complaints go to AHPRA or if patients make a complaint, they often become more litigious as they start entering information into the online portal. If you as a practice are open to feedback and have, whether you have a box for patients to make complaints or suggestions, have information on your website and invite feedback from patients, it's often really useful for patients to feel like they've got an opportunity to air their grievance. Otherwise, they might go home and talk to their family member and say, look, this is what happened. And all of a sudden, this becomes bigger than Ben-Hur because they've started to rehash the whole situation in their head. They now go into the Health Complaints Commission website and see the types of complaints. Oh, gosh, that's what happened to me too. And all of a sudden, it's really easy for them to make this complaint. We really see it important to offer to do it in the practice rather than them doing it outside of the practice. Patient selection and identifying alarming behaviours is often important in preventing complaints and claims. It's important that you work collaboratively with the support team, including the practice manager and admin staff, to identify patients and decide as early as possible to terminate the relationship if you identify that patients really are exhibiting really inappropriate behaviours. You may need Avant or whoever your MDO's assistance before you do that, just to prevent it from becoming a complaint in itself. And managing difficult behaviours with increased consultation time to reduce anxiety, or consulting with a patient, but manage them very carefully and document impeccably. Again, if there's a complaint or claim, we will rely on your medical records to be able to assist in defending that complaint and claim. Practically though, if a patient contacts your office and is rude with your staff or exhibits inappropriate behaviour when communicating with staff, this should be alerted to the doctor so they can address it direct with the patient. It's amazing how patients can almost be keyboard warriors with the admin staff, but they'll be puppy dogs and pussycats when they're in front of the GP. Not always, but sometimes. But it's really important that it's directed to the patient to ensure that they're aware that they have exhibited inappropriate behaviour and that behaviour won't be tolerated in the practice. Directing patients to your policies and procedures on your website around behaviour policy. Again, if you feel that it's required to get them to sign a behaviour policy or agreement to ensure that they're aware of what the ramifications will be if they continue to exhibit inappropriate behaviour. But it's really important to make patients aware that they can complain to you and that you're open to it and that you'll take it seriously. And report appropriately, and that you'll respond within a certain time frame. So again, getting back to managing patient expectations, we recommend that you have a staff member responsible for complaints. It's often the practice manager, but also nominating somebody else. So if the practice manager is not there, that somebody can take responsibility for it. Keep a record. Have a policy or process in place for how the practice manages complaints and feedback. If the complaint's substantial, ask for it in writing just to make sure that you really understand what the issue is. When you receive a complaint, we also recommend that you respond within 24 hours, even if it's just to say, look, we're looking into it. Thank you for your feedback. We're sorry we've let you down, and managing their expectations. And if it's going to take longer than 24 hours to get back to them, just give them an understanding of how long this is going to take, what process you might be taking, and just let them know and confirm that, yes, we do have a complaints policy and we're following that for you. But it's worth putting in the effort to address complaints early, just to avoid them going to all of those other websites. Patients often just want to be heard and understood. They often want an explanation as to why they were let down, an apology that we're sorry we've let you down in this instance, we're sorry that this particular staff member's approach to you was not appropriate, letting them know that something might change, because patients often want something to change, but sometimes things can't change. So making sure that patients are aware that, look, we have this policy, we're following through on it. Unfortunately, we can't change anything in this instance, or the process, this is what the process is and we're not able to change. But letting them know, look, we understand and we'll make sure that we work better in future. What not to do, and we often see this at Avant when this does happen, is to ignore the problem. Just pretend it'll go away and it'll all be good. Accusing the patient, it really, going back to accusing the patient of being problematic may provoke the patient. They might become angry, and then there's counter blaming. Telling the patient that there's nothing wrong or that there is nothing that you can do for him or her may trigger persistent attempts to prove that the problem exists. Attempts to solve problems with psychopharmacology, unless carefully introduced and based on correct diagnosis, also may prove problematic. But just making sure that patients are kept in the loop, acknowledge that there is a complaint, that they've got a concern, and trying to resolve it with them. If there is a complaint, gathering the facts, reviewing the medical notes if it's a clinical complaint, looking at copies of reports, records of phone calls, discussions with relevant staff, checking local protocols and checking what happened on the day, making sure you really understand what the complaint is about, and trying not to blame anyone. Again, in our practice, if we received a complaint about a staff member and an interaction, so without blame, we would talk about what happened and how we can improve for the future and what we could put in place to avoid this happening in the future. Really understanding who the complaint is about and what the patient wants in making a complaint. Again, often they just want an apology and an acknowledgement that, yep, I didn't get exactly what I should have got. The interaction with the practice was not appropriate, and I just want to know this isn't going to happen again. If a referral or follow-up is required, work out a management plan for the patient. And making it really obvious to patients that you've got that process in place and really easy for them to give you all types of feedback. A note on the bottom of an email in bold if you're communicating in email would be appropriate, or a note on your website. I know my general practice has a box for feedback. I'm not sure how much feedback they get in it, but at least it's there, and I know if I wanted to put some feedback in, I can. In their instance, it's right in front of the reception desk. I probably wouldn't put it right in front of the reception desk because people are probably less likely to put something in there, but having it in a place where somebody can pop their feedback into a box and be confidential is a really good opportunity. Even if you've got an email address through your website, that they can provide confidential feedback that way. Adopting a receptive attitude to patient feedback and complaints. So when it happens, use words like, I'm so sorry to let you down. Let me take this to the doctor and we'll come up with a resolution. Even if you don't intend to change anything, this tactic gives you time to respond and think about how you might respond to them. And obviously, if it is something that could potentially turn into a bigger complaint or claim, you should contact your MDO to seek advice as to how to respond to the patient. If you receive a patient complaint, ensure that the patient understands the team work together to resolve it. And that stops them trying to get to the doctor directly. Often they think that the doctor's the only one that can deal with a problem or complaint that they might have. If the practice team cannot resolve the complaint, contact your MDO for advice on resolving the complaint before any further action is taken, to avoid unnecessarily upsetting and aggravating the patient and having them feel like they've got no other alternative but to make a formal complaint. Develop a system to record, review and manage complaints, and include how you will advise patients on the progress and outcome of their complaint. It's often really useful also if you have staff meetings or practice meetings to have an agenda item. So if you do get feedback or complaints from patients, use that as an opportunity to look at it and have a discussion as a practice as to how it was managed, anything that changed as a result. That will often also, if you've got a register of complaints, will give you an opportunity to see if there's patterns. And then that way, maybe there's something that's more of an underlying issue. Having a written process that includes how you're going to gather the information about a complaint, outline how the patient may complain, so whether it's on the website or a box or email address, what the initial response to a complaint will be, what the receptionist might say to the patient and how they inform the patient about how the complaint will be managed, where and when complaints are discussed, example, agenda items at practice meetings, and how you might work with patients to resolve their complaint or claim. And it might be relevant in many cases, but it makes the patient feel like you really care about them, to see that actually you've got a process and you take these things seriously and you use it as an opportunity to improve and to avoid this happening in future to anybody else. And make sure that you're also providing prompt, open and constructive responses to patients, ensuring complaint doesn't adversely affect the patient's care. In some cases, it may be advisable to refer the patient to another practitioner or another practice, depending on what the complaint is and if the trust has been lost as a result. And also how complaints are documented and where information is kept. So you might use a template that's filed and retained for future reference. If a patient has a significant complaint, consider not charging the patient for that particular consultation. If it's a realistic concern, often patients might feel less likely to make a formal complaint if they feel like, okay, well, they didn't charge me, even though I really feel like I didn't get what I wanted on the day. And look out for each other. It's really challenging dealing with some of these inappropriate patient behaviours, and taking care of yourselves. So we'll briefly go through ending the doctor-patient relationship, just so that we've got some time for questions if there are any. And often this comes down to a decision for the doctor, whether they feel like the relationship with the doctor has been degraded to the point where the trust has been lost. Depending on whether you've got a group practice, it might be appropriate to have another doctor in the practice take on the care of the patient. So when is it okay? Again, trust is particularly important for that doctor-patient relationship to be positive. It's acceptable and reasonable to determine that a clinical relationship is no longer therapeutic. It could be because the doctor feels like they can no longer provide objective or dispassionate care to the patient because they have particularly negative feelings towards the patient, or they're at the other end of the spectrum. So safety of you and the practice staff are also an important consideration. So thinking about it from that perspective as well. It's really important to avoid allegations of discrimination. So take care that ending the clinical relationship is not to be interpreted as being based on reasons such as gender, sexual preference, marital status, disability age, or HIV status. And these decisions aren't to be taken lightly. From the moment that you do decide that a clinical relationship should end, make sure you plan ahead. Consider how you're going to inform the patient. Talk to senior colleagues and peers. Have maybe the doctors in the practice have a discussion. If one particular doctor is feeling particularly uncomfortable dealing with that patient, if other doctors are happy to take on their care. Consider advising your MDO, particularly if there's a serious breakdown in case of future complaints, and follow a clear process. At least if you've got a clear process that's documented, making sure you're discussing it with the patient, clarifying the expectations, prepare to justify the decision to the patient, and also if there is a complaint or claim, being able to justify the reason why this decision was made. Prepare a letter and formal letter to the patient to inform that unfortunately the practice is no longer able to care for them, and if they can provide contact details for an alternative care provider, that their records will be sent with their consent, and provide the records to the new doctor, and make sure that records are provided in a timely manner too, to ensure that there's that continuity of care isn't broken and not actually causing another reason for the patient to make a complaint. So that's it for all of my slides. So if anybody's got any questions, have you got any questions, Natalie?
No, we've obviously done such a fabulous job that everybody's questions are answered, which is always it's the outcome we always want.
That. Yes, we can talk through that scenario if you wanted to.
Yeah, certainly. So I was a GP that has done all the things that we talked about in terms of offering a second opinion, offering a referral to a specialist, and the patient refusing to leave and escalating to the point where the police had to actually be called. And so I think the sort of questions that have come out of that scenario is really around that, that one patient with dominating that amount of the practitioner's time, ruining the appointments of other people. That patient left and there's no reprimand for this patient's behaviour. But I think that really speaks into your conversations about having really robust policies about how you manage things in your practice, whatever, the practice staff's responsibilities, what strategies you can utilize in those situations. And, having a bit of a discussion within the practice team, like, it's like when you do your CPR training and you practice your scenario in the clinic, it's the same sort of things. If we did have a patient that was refusing to leave, how would we be supportive and how are we managing this?
Absolutely. And it can be really challenging. And even the best scenario planning in the world is not going to be able to plan every scenario. But the more you plan and practice and talk about it, the better you're going to be able to manage it should it happen. But certainly, number one priority needs to be managing safety for all. So making sure that you have, if this interaction was with a doctor, making sure, a lot of practices do, some don't have an alarm that they can alert the reception staff that something isn't going right in the consultation room, so that whether you've got a distress signal that can go through so that admin staff know to contact police or external services, having all of those plans in place and systems in place to ensure that there's a way that can be managed to ensure that the safety of all that certainly is the most important. But yeah, you're right. Educating the patients about the expectations around, look, this is the amount of time that we've got. This is what we can do. If you're not able to meet their expectations in that period of time, offering, look, we really need to be able to make a longer appointment. This is going to take a little bit longer than what we've got. Please make another appointment to come back when we've got the next available appointment. And for that one, we won't bill you an out of pocket. So then they don't feel like they've got all of these issues that they can't deal with in one consultation, and now they're going to have to pay more money. So it's really important to make sure that you're able to offer alternatives and hopefully satisfy the patient. We can't satisfy all patients, but doing what we can do, and really good for admin staff and practice managers to network with other practice managers and other admin staff, because the stories we hear are amazing. And to talk to other people who have gone through some of these challenging events and to talk about how they've managed it. I'll often say to people, the most valuable part of any conference I ever went to was networking with everybody else to be able to scenario plan, and how did you deal with this difficult position, and how did you manage this? And that's really worthwhile. So I would certainly be advocating for networking with other practice managers and admin staff, and for doctors as well. Peer support is really important. Ensure you've got that support within the practice where you can seek the input from other doctors and practitioners in the practice, but also having external networks of people who aren't involved in your practice to think about, well, how do you manage these scenarios in your practice? And it's a really good opportunity to see, gee, they've done it really well over in that practice. Maybe this is something we can adopt in ours. So keeping an open mind is really important.
Absolutely. And I think too, just the importance of communication, and particularly, when I have worked as a clinician, um, a lot of these behaviors, most of the time, it's nothing to do with you as the practitioner or you as the receptionist. Unfortunately, working in healthcare, we don't see people at their best very often. We're often seeing them in times of stress, illness, grief, and just offering the opportunity as a circuit breaker, because I think sometimes, even without trying to escalate, without, that opportunity to exit, and just that saying of, I think we both need to take a breather. Can I get you a glass of water? Would you like a minute? And, it's not always going to work, but it's offering an out and offering that patient an opportunity to de-escalate or reflect. So,
Absolutely. Yeah, absolutely. And just to let them know that they're being heard is often good to help de-escalate a situation.
absolutely. Absolutely. All right. Well, unless there's any other questions, so nothing has popped up in the Q&A. So I'm going to have to
We're running a
de-escalate my.
little bit ahead of time the night before a public holiday.
Everyone's keen. Everyone, the party pies are ready. We're excited for a. I'm not going to allocate sides. I'll let people choose their own preference. So I'd like to thank you so much. I hope everyone's found it as useful as I have. So I'm going to have to de-escalate my cat. Um, you will receive a attendance certificate within a few weeks' time. We'll also send out an email asking for feedback. So please let us know what you found useful, what sort of education things you would like to see in the future. There's a QR code there if you've got your phone handy and you can manage this newfangled technology, and that'll take you straight to the feedback. But thank you so much for your evening, Cheryl. Thanks for your time. It's been
Welcome.
wonderful.
Thank you. Thank you, everybody, for your attendance. And hopefully it's been useful. And please, as Natalie said, if you've got any areas where you'd like some resources that have come from tonight's presentation, send that comment through. And when Natalie's sending out the slides next week, then we can include some links to some other resources for you as well.
Absolutely. I was going to say another question's just popped up in the chat
Yes.
now around someone who works in one of the priority primary care centres, and obviously their scope of their activities and declining patients. What I would say is if you wanted to get in touch with us at the PHN, and we can do some workshopping around this as well, because obviously it's a slightly different than your standard general practice environment. So please reach out and we can do some work around this with you.
Sounds good.
Have a
But certainly
lovely.
from a scope of practice perspective, there's lots of resources out there. So if
Absolutely.
staff aren't feeling particularly comfortable with what they're being expected to do, there's always opportunities for professional development to explore other opportunities. We often talk to practices where they've got staff who don't feel comfortable doing what they've been asked to do. And then we'll look at what other options there are for them. But as you said, there's lots of resources out there.
Wonderful. Well, and with that, I think we'll let you all off to your long weekend and we'll see you at the next education session. Have a wonderful evening.
Thank you. Bye.